I'm Vicki Templeton, and I'm representing the nutrition team, and we want to bring you some updates to our cue-based feeding guideline today. We plan to go live with these changes on November 1st. We've been using a cue-based feeding method to orally feed infants in our NICU since January of 2020. The goal was to decrease the length of stay, decrease the time to full feeds, decrease the incidence of feeding problems affecting our babies long term, and increasing the number of babies on any of mother's own milk at discharge. These changes were made as a result of physician feedback and data results. The new changes are respiratory criteria for beginning oral feedings. We tweaked that just a little bit. It's included in the cue-based feeding algorithm. We have a new breastfeeding scoring tool, and that will be an EPIC, and we have a new breastfeeding algorithm. The algorithms will be available in badge size, and the algorithms and scoring tools will also be hanging on the sides of the computers in each pod, as well as posted in every pod. They will also be located in the cue-based feeding book at the front desk, and you may get one and put it at the bedside clipboard if you want a larger copy. Our oral feeding readiness tool, I'm not going to go through this because we have not changed it at all. There's no change from our prior readiness scoring tool. You're going to score before all oral feedings. Now, all of these scoring tools will have a daily score average, which will populate as a smart phrase for the physicians. Now, our quality scoring tool is now going to only be used for when you bottle feed a baby. So it is labeled as bottle feeding quality scoring tool. The scoring tool is exactly the same. We did not change it at all. It's now just used for bottle feeding, and you're going to score after all bottle feeds. Now we have our breastfeeding quality scoring tool. This is the new addition to our quality scoring. It will be used for breastfeeding only, and you will score after breastfeed. We actually have 5 categories in that. It's going to score just the same way as our bottle feeding quality score. You have a total of 10. You have a 0, a 1, or a 2. And our breastfeeding quality scoring tool is going to have the categories of mother's milk supply per pump, breastfeeding latch, latch minutes, physiologic stability, and stress. Your physiologic stability and stress are about the same as the bottle feeding. So now let's go through our milk supply per pump. This is something that you are going to have to ask mother when she comes before she breastfeeds, or at least once a day, so you will know how to chart it. And these first 3, the mother's milk supply, the breastfeeding latch, and the latch minutes, you will use to determine how much you are going to gavage or give a bottle afterwards. You'll use that for supplementation. So the milk supply per pump, a 0 is minimal, less than 1 feed per pump, or the first few days of life. A 1 is moderate, which is 1 to 1.5 feed per pump, and or your baby's still hungry. 2 is a large supply, greater than 1.5 feed per pump, and or established breastfeeding with satisfied baby between feeds. Now let's look at our breastfeeding latch. 0 is your baby's not interested at all. No latch, or he may latch intermittently for a short time, but he keeps falling off, or he's unable to relatch. No swallow, or minimal uncoordinated swallow. The baby may be sleepy. 1 is latches well with rhythmic sucking, swallowing, and milk transfer. Tires as feed progresses, and or baby keeps falling asleep, baby is learning. A 2 is he latches well with long rhythmic sucking and swallowing and milk transfer, and the baby is satisfied. So you can see on your latch a 0, that baby's not really going to get anything. A 1, he's going to get some, but he's not going to get his full feed because he tires as the feed progresses. And then a 2, he can usually take the whole feed by breastfeeding. So now let's look at our latch minutes. A 0 is less than 5 minutes. A 1 is 5 to 10 or 15 minutes, and the baby is still hungry. In other words, your smaller babies who don't have a real strong suck may need a good 15 minutes to be satisfied. Those that are bigger might only need 10. And also a small baby may not show continued hunger. He might be too sleepy. A 2 is greater than 10 or 15 minutes, and that baby is satisfied. Healthy big babies may only need 10 minutes to be satisfied, but if they want to go 15 or longer, that's great. Physiologic stability, that has not changed at all, so I'm not going to go through that. Stress, the stress signs are the same, but I want to go through one little thing on the 0. They must display 2 or more stress signs, but those signs are unrelieved as the breastfeeding attempt progresses. A 1 is the stress signs present intermittently during the feed or as the breastfeeding attempt is beginning, but it's absent once that baby is able to latch. And then 2 is no signs of stress present. So now let's look at our total scores. You're going to continue with the current breastfeeding attempt if the breastfeed assessment is greater or equal to 5. You're going to stop the feed if the breastfeeding assessment is less than 5. You're going to gavage per algorithm or bottle feed if mother prefers and cues are still present. And those guidelines as far as whether to gavage or bottle feed are listed in the algorithm. You can continue with breastfeeding or nuzzling at the breast if milk supply is the only 0. That will increase the milk supply. Okay? So now, let's look at the changes to the Q-based feeding algorithm. I'm only going to go through a couple of sections on this algorithm, and the first section that I'm going to go to talks about the respiratory criteria. Our respiratory criteria for oral feeding is less than 2 liters high flow nasal cannula. That has not changed. In other words, you do not have to start scoring your baby until he gets to 1.5 liters nasal cannula. However, we did put a caveat in here. They may feed on 2 liters high flow if the physician orders it. And they also have to have a readiness score greater or equal to 5 with no zeros. But speech must do the first feed if they're on high flow 2 liters. We're not going to do the first feed, speech will do it. So if it's on the weekend and speech isn't here, or at night and speech isn't here, you're going to wait until speech can come to do that first feeding. So when you would start scoring is when they write the order for that baby to feed on 2 liters. They still have to get their 4 scores, okay? So now let's talk about the 4 scores. That's your next box that's underneath here. Once the criteria is met for beginning oral feeds, you're going to get 4 readiness scores greater or equal to 5. It is okay if these 4 scores have a 0 because you're not going to feed on those scores. And then the next one that you have without a 0, you would feed. So this is another caveat we added. If there's no feeding tube present, you do not have to get 4 scores. Just feed at the first readiness score greater or equal to 5 with no zeros. Those are going to be the babies that come over from bigger babies from L&D. They don't want to start an IV. They want to just go ahead and feed, or baby coming from newborn that they want to go ahead and feed. So now let's move on through. These next ones I'm not going to go through because they're the very same. So now let's come down to the other change that we have, and that is on the blue box underneath the green breastfeeding algorithm boxes. The blue box says you fed your baby and now he has a quality score of greater or equal to 5. The change that we made here is that has to do with how much feeding the baby is getting. They have to be on 160 mLs per kilo per day to be able to refuse the bottle if they take 85%. In other words, say the baby was only on 130, 140, 150 mLs per kilo per day. He wasn't on total full feeds. They may have been considering it, but he may be fluid restricted or something. And if he doesn't take 85%, if he just takes 85% for multiple times a shift, he may only get 115, 120, 130 mLs per kilo, and that's not enough to grow, okay? So let's look at these boxes here. Your weight is less than 2 kilos, or your feeds are less than 160 mLs per kilo per day. You're going to gavage the remainder if the infant does not complete the volume in 30 minutes or he shows signs of disengagement or distress. And then the next blue box is the weight is greater than 2 kilos and your feeds are at 160 mLs per kilo per day. You do not have to gavage if he takes 85% or more of the feeding. You're going to gavage the remainder if he takes less than 85%, or the physician can order it due to insufficient weight gain. Okay, I'm not going to go through the rest because none of that has changed. So now let's move to our breastfeeding algorithm. This is new, okay? So let's look at the little box on the left-hand side. If your baby is 32 to 34 weeks, we want to breastfeed only, no bottles, breastfeed only for at least 3 days and pair it with gavage. Now, if the baby is 34 weeks, breastfeed for at least the first feed. You can supplement with bottles if mother agrees. And the reason for the 32 to 34 weeks is that baby's not going home. We've got time to just breastfeed for 3 days. The greater than 34 weeks, that baby could go home soon. So you may need to introduce bottles sooner, but at least try to breastfeed for the first feed. So our milk supply we've already talked about. And the next part is the decision to breastfeed is validated. Infants on bolus feeds with a minimum daily volume of 120 mLs per kilo per day. We did put a caveat underneath that. May breastfeed if he's on less than 120 mLs per kilo per day, if he doesn't have a feeding tube or the physician orders and follow the algorithm. So in other words, that baby comes over, mom, say from newborn, he doesn't have a feeding tube, she wants to breastfeed, and he's on smaller feeds, say 30 or 50 per kilo, just starting out, he can go ahead and breastfeed, okay? He doesn't have to be on 120. So let's move on to, you want to also get lactation to assist with the first few feedings if possible. But don't delay the attempts if lactation's not available. And then complete your breastfeeding quality score after each feed. And you're going to follow the supplementation guidelines as listed below. So then you're going to allow your baby to breastfeed. Now we have a breastfeeding quality score greater or equal to 5. And you have, look at the first blue box down there, you have a minimal milk supply, a latch score is 0, a latch time is less than 5 minutes, or your baby is disinterested. Any of those, you're going to gavage it all, okay? Because that baby's not going to get much. Or if he's greater than 34 weeks, you may offer the entire feeding by bottle if mother prefers, and if the baby cannot complete the bottle, gavage the remainder. Now the baby also has to still have cues for you to give a bottle, all right? So now let's look at the next one, and that's a moderate milk supply, a latch score of 1, a latch time of 5 to 10 or 15 minutes, and that baby is still hungry. You're going to gavage half of the feed. Or if he's greater than 34 weeks, you may offer the bottle if cues are still present and mother's in agreement. So our last one is you have a large milk supply. Your latch score is 2. Your latch time is greater than 10 or 15 minutes, and that baby is satisfied. You don't have to gavage at all. No need to offer a bottle unless mother really wants to. And you're going to continue with breastfeeding attempts as mother's available. Now for all supplementation by bottle, you're going to do the bottle feeding quality score and follow the Q-based bottle feeding algorithm. In other words, there's a scenario you could do 2 quality scores. One would be the baby breastfeeds. You do the breastfeed quality score, and then the baby supplements with a bottle, a bigger baby, and then you have to do the bottle feeding quality score. Because the baby could get a great breastfeeding score and a poor bottle score, or vice versa. He could get a poor breastfeeding score and a great bottle feeding score. So now let's look at the next part. You've got a quality less than 5. Any milk supply at all. A latch is 0 or 1. Latch time is less than 5 minutes. Stress signs are unrelieved during the breastfeeding attempt, or he's having spells. You're going to gavage the full feeding, or if he's greater than 34 weeks, you may bottle feed if he still has cues. And continue the breastfeeding algorithm. Just make sure that you provide enough lactation support, and if you're having a lot of scores, greater than 3, less than 5 in 24 hours, consult speech and lactation with the mother to assess for any breastfeeding needs. We're going to monitor daily weight during the transition from gavage to breastfeeding. So now let me go to compensatory techniques. There's only a couple things I want to mention here. One, some people have told me that some people are selecting every single one. You don't have to do that. I only want you to select the compensatory technique that you use for that specific feeding. In other words, if you pace for this feeding, you're going to put pacing. If you don't pace for the next feeding, you're not going to select pacing. Okay, just select what you use. And just as a reminder, please do not use chin or cheek support. That can lead to aspiration because the flow can be too fast for the baby to handle. Spillage is the baby's way of protecting his airway. Now let's talk about daily rounds. Don't forget to discuss in rounds the infant's feeding progress, parent involvement, any breastfeeding and feeding problems. So we've also had a lot of times nurses will request a speech consult on little babies because the big slow flow nipples too fast for them, and the docs are resistant to that. They would just say, well, the baby's too small. Well, we've explained that the reason we actually need speech involved is because we do not have access to those nipples without speech. So the new thing is all babies less than 32 weeks at birth are going to have an order in the admission set for a speech consult at 32 weeks at the nurse's discretion for a nipple assessment. So if your baby's doing fine on slow flow, you don't get the speech consult. But if you feel the baby needs a speech consult, you do not need to ask. Just call speech and make a note in the comment line that you are waiting for a speech assessment if you feel it's unsafe to feed with a slow flow nipple. Now, if that happens and it's, say, the weekend or at night, and you can't get speech until the next day, still, if it's not safe to feed that baby, don't, and then just put a note, okay, on the comment line. So a couple of things I want to clarify on EPIC charting. Non-nutritive sucking versus breastfeeding. I don't know if we're not doing non-nutritive sucking or we're just not charting it. So I want you to chart in the non-nutritive section breast if non-nutritive sucking occurs during skin to skin. Any mother who is pumping and providing breast milk needs to do non-nutritive sucking and then needs to do breastfeeding. So we want to, when that baby's on a cannula, they can do non-nutritive sucking, and lactation can also help the mother and baby with this. And that's when the baby is allowed to nuzzle, lick, or even attempt to latch or practice at the breast. So now nutritive sucking should start, non-nutritive sucking should start at 30 weeks if there's no respiratory distress. Do not chart breast in the method of feeding section or the feeding route section, since it was not actually a feeding attempt. And you also, for non-nutritive, do not need to complete a breastfeeding quality score for non-nutritive sucking. Breastfeeding, you're going to chart breast in the feeding route section if the baby is attempting to latch onto the breast for a nutritive feeding. And when breast is selected as a feeding method, the breastfeeding quality score will populate for you to chart on. You want to chart also the number of minutes latched per breast, and the total minutes will populate. Also, we're going to have a breastfeed occurrence line, just like there's a stool occurrence, and you're going to chart 1 for each nutritive breastfeed, and that will populate to the physician's INO section. I want to give you an example of a baby that went home breastfeeding successfully, and we'll call that baby H. He breastfed many times a day. He started with non-nutritive sucking for a few times, then moved on to breastfeeding. Pat had this baby and was very proactive in enabling the mother. And you're still compliant if the mother does non-nutritive for a few times before she actually breastfeeds. However, still allow mother to do nutritive breastfeeding before you give a bottle, if at all possible. And this will help her to breastfeed successfully. And a couple of scoring and charting reminders. You're going to begin scoring at 32 weeks and less than 2 liters. Nasal cannula, the exception is if the physician orders it on 2 liters. Then you begin scoring when you get that order, and notify speech to do the first feed. And another thing that I think would help us all is if we would chart on the readiness comment line to show the progress of those first 4 scores. Prior to oral feed. And the example is, say, score 1 of 4, score 2 of 4, score 3 of 4, score 4 of 4, and that will help everyone to know when the 4 scores have been obtained and the baby is ready to begin oral feeding. Also put it in the handoff. The other exception is if there's no feeding tube present, the baby may feed as soon as a readiness score allows. Also, if your baby has a good score, but you are waiting to feed for numerous reasons. It could be the baby is maybe breastfeeding only, or mother's coming to do the first feed, or you're waiting for a speech consult, or maybe even speech put a hold on PO feeding. Chart that reason on the readiness comment line. That way we know that it's not that you just didn't feed the baby, but there was a reason for that. Okay? So look at your bottle feeding scoring. Use it for all bottle feeds, even if bottles are used to supplement after breastfeeding. And on bottle feeds, the exception to scoring every section is to say you fill the bottle, you try to feed that baby, and he won't open his mouth. He's going to get a 0 for suck, and you don't have to fill out the rest of it because you can't assess if he didn't actually feed. So our breastfeeding quality score, use it for all breastfeeds, score every section, and you will need to score every section of this so the physicians can know whether it was an effective breastfeed or not. And you're going to need the milk supply, the latch, and the latch minutes to follow the algorithm. Also remember, your baby's less than 34 weeks. Mom needs to try to breastfeed for the first 1 to 3 days and follow the algorithm and pair it with gavage. And then if that baby's greater than 34 weeks, at least try to do it for the first feeding and follow the algorithm. So now we've got a little bit of data that I'm going to move very quickly through this. We have enough data to compare 2019 to 2020, the babies who've been discharged so far. So we're looking at length of stay and number of days to full oral feeds here. And the first green column in every group is 2019. The others are 2020. So length of stay, you want to be lower. And you can see we have made the most progress. The first 2 columns are every baby that's in the study. Then that's less than 32 weeks. The next columns, we divided it by babies that are sick with BPD or NEC, babies that are less than 29 weeks, and then healthy ones, and then babies 29 to 32 weeks and healthy ones. And you can see where we're making the most progress is the sick babies. Look, 98 to 96 to down to 90 days. And our less than 29 weeks, we have gone from 83 to 78. And your healthy ones, we've gone down 9 days, 74 to 65. And now looking at our days of full oral feeds, every category is better. So look especially at your sick babies. We've gone from 24 down to 15 days. And then our VLBWs, less than 29 weeks, we've gone from 20 down to 15, and healthy ones, 21 to 16. So that is very encouraging, and you're all doing a great job. Now looking at the next, this deals with mother's own milk at discharge and breastfeeding at discharge. And all of this has kind of come about as a result of seeing some of these results. Receiving mother's own milk is so important in affecting the baby's length of stay and his neurodevelopmental outcome. It decreases NICU complications. So you can see in 2019 on mother's milk at discharge, it was in the 60th percentage, and now we're in the 40s and low 50s. So we really need to improve that. Babies with any breastfeeding at discharge were actually a little bit better, which is great. In 2019, we were 26 to 29 to 30%, and now we're 30 to 33%. So it's a slight improvement in all of our babies. So these changes that we've provided with all of this should help and provide better guidance as we attempt to help our moms and babies breastfeed, and also provide better charting as well. Hopefully, as more of our mothers breastfeed, it will also help to increase the number of babies receiving mother's own milk at discharge. So I want to go through one last thing right here, and that is how well we're doing with the whole guideline here. If you look at your compliance chart, you can see that scoring compliance and appropriate feeding decisions are greater than 90%. That is exceptional. I've looked at a lot of studies, and this is one of the top ones. We're doing at the very top of what people mostly do. They're usually greater than 80%, so I'm so excited about that. Beginning feeds as soon as scores allow. We still need some work on that. That was about 57%, but we're beginning to see improvement. May, we actually improved to 75%, and the following months are also looking better also. You're all taking excellent care of our babies. Our babies are going home to their parents sooner, and they thank you. A healthy, happy baby leaves for happy parents. Keep up the good work. One thing I want to leave you is there's a term that my husband uses, which is a lot, which is to know your why. Why do we do what we do? We do this because we love babies, and we want to see them healthy, and we want to help these families and these babies go home healthy. And that is my why. I call that a white-hot why, which is as strong a why we do. And sometimes what we do is hard. Sometimes it takes extra time, especially helping moms breastfeed. But if we remember why we're doing this, that will help us to continue doing what we do to help these babies. So everybody keep up the work. You're doing a great job. Thank you.